of 56 unit per liter. Cord TSH was normal, and she also has hypoglycemia with dextrostics of 3.1 millimole per liter. In terms of electrolyte, she has hypocalcemia, evident by ionized calcium of 0.9 millimole per liter, serum calcium of 1.63 millimole per liter, and corrected calcium of 2.03 millimole per liter. Phosphate was normal. She also has hypomagnesemia with magnesium of 0.64 millimole per liter. Arterial blood gas shows there is uncompensated respiratory acidosis with hyperlactatemia with lactate of 2.7 millimole per liter. CRP was within normal range. She has elevated procalcitonin with 13.82 nanogram per ml. So this is the ECG performed at 1 hour of life. It shows heart rate of 230 beats per minute, and it shows atrioventricular nodal reentrial tachycardia with short RP interval. So in summary, Madam S is 29 years old, primary gravida, delivered a preterm baby girl at 34 weeks gestation, who was large for gestational age. The baby had several notable medical findings, including dysmorphic features with hypertelorism, micronectia, almond-shaped eyes, and low-set ear. She also had a posterior neck mass. She has a respiratory distress requiring intubation and tachycardia at birth. Further investigations revealed imbalances in electrolyte, hyponatremia, hypocalcemia, and hypomagnesemia, hypoalbuminemia, hyperbilirubinemia, and slightly elevated liver function test, hypoglycemia, and elevated procalcitonin level. Okay, actually this is a case where there is a strong suspicion of genetic syndrome with multi-organ involvement as evident by tachycardia, posterior neck mass, respiratory distress, hypoglycemia, and electrolyte imbalance. On top of that, we should not forget that the fact that the baby might have additional factors such as sepsis and prematurity, which might contribute to the overall clinical picture of this patient, and worthwhile for us to have a discussion on it. So I broke down into two, dysmorphism with neck mass. So I divided into two main groups, genetic. Genetic syndrome that I consider are Costello syndrome, Noonan syndrome, and Turner syndrome. Congenital infection that I consider is congenital cytomegalovirus. For symptoms such as respiratory distress, electrolyte imbalance, hypoglycemia, it could be due to underlying genetic syndrome, sepsis, GBS bacteremia, early onset pneumonia, prematurity, including respiratory distress syndrome. Okay,
sorry,
so...
can I just stop you there, Dr. Lim? In problems that you have summarized, can you tell us a bit more about sugars? You say it's hypoglycemia. Is that hypoglycemia? One? At how many hours of life take?
The dextrosy was taken of life.
Yeah, and so to comment on 3.1, because there are a lot of students here. You need to clarify things. Is that the usual cutoff level for hypoglycemia at 1 hour, 3.1?
At 1 hour of life, if DXT less than 2.6, we consider there is a hypoglycemia.
Yeah. In fact, it tends to be even lower, isn't it? It can be even 2.2 within the first 2 hours. So 3.1, that's probably acceptable. Yeah. Okay. And you said there is a neck mass. Should you not give us a discussion on the differential diagnosis of what neck mass is? You're going to discuss that with the differentials. Are you going to tell us what a neck mass could be?
I included in the genetic, when I discuss on the genetic syndrome.
Yeah, but what does the neck mass mean?
In this context of case,
is it anterior neck mass, posterior neck mass as well?
It's a posterior neck mass.
So what could that be?
It could be due to lymphatic dysplasia, lymphatic malformation, as evidenced by the prenatal and fetal anomaly scan shows there is a cystic hygroma.
Okay. So antenatal fetal scan did show it is cystic hygroma, wasn't it?
Yep.
All right. Okay, go on.
So, point for Costello syndrome, dysmorphic features. The patient exhibits several characteristic dysmorphic features, including hypertelorism, micronectia, almond-shaped eyes, and low-set ear. These features are consistent with the typical facial appearance seen in Costello syndrome. Polyhydramnia. Bandam S had polyhydramnia during pregnancy, which is also associated with fetal overgrowth seen in Costello syndrome. The fetal anomaly scan finding shows there is a presence of cystic hygroma and enlarged cisternal magna on the fetal anomaly scan. While this finding can be seen in various conditions, they are consistent with abnormalities seen in Costello syndrome as well. Posterior neck mass could suggest potential lymphatic malformation, which are also associated with this syndrome. Macrosomia and macrocephaly in Costello syndrome can present with macrosomia and macrocephaly. Metabolic and respiratory issues, the presence of respiratory distress requiring intubation metabolic abnormality as indicated by blood investigations are relevant. Costello syndrome can involve various systemic manifestations, including respiratory issues and metabolic disturbances. ECG abnormalities, as shown in this case, FVNRT, is not pathognomonic for Costello syndrome, but can be associated with certain cardiac abnormalities seen in this condition. Point against Costello syndrome include normal knuckle translucency. Costello syndrome can be associated with structural anomalies detected on fetal anomaly scan, but normal knuckle translucency does not typically suggest this syndrome. Absence of reported cardiac murmur or specific cardiac anomaly. While an abnormal ECG showing AVNRT is noted, specific congenital heart defect or commonly associated with Costello syndrome were not mentioned. Normal female genitalia. Costello syndrome in female can sometimes present with urogenital anomalies, including anomalies of the female genitalia. So the absence of such finding is not supportive for Costello syndrome in this case. Further history and examination, a thorough clinical assessment should be conducted. So for family history, we should obtain a detailed family history to identify any potential familial occurrence or history of similar clinical features. Look for any caused facial features such as full lips, large mouth, full nasal tip, curly or sparse fine hair. Assessing for skin abnormality such as papillomata, hyperkeratosis, and redundant skin fold, which is common in Costello syndrome. Gastrointestinal and MSK evaluation, we should screen for GI issues as feeding difficulties and gastroesophageal reflux and MSK anomalies such as hip dysplasia, ulnar deviation of the wrist. In terms of neurological assessment, we should screen for neurological features such as any hypotonia and seizure. Last but not least, Costello syndrome can present with specific ocular findings such as dominant epicenter fold, ptosis, strabismus, and refractive errors. Further investigation would order, including genetic testing. Diagnosis of Costello syndrome is confirmed through genetic testing, typically identifying mutation in the HRAS gene. So given the clinical presentation, genetic testing will be crucial to confirm or rule out this diagnosis. Performing an echocardiography also important to assess for hypertrophic cardiomyopathy and pulmonary, which are frequently associated with Costello syndrome. Ultrasound of neck evaluate the posterior neck mass for any evidence of lymphatic malformation, external compression at neck region. Ultrasound of brain to look for dilated ventricle, and ultrasound KB to look for any renal dysplasia, dilated renal pelvis, hydronephrosis. Second genetic syndrome that I will consider is Noonan syndrome. Here are the points supporting Noonan syndrome. Dysmorphic features. The newborn baby exhibit hypertelorism, micronectia, almond-shaped eye, and low set tail. These facial features are commonly seen in individuals with Noonan syndrome. Polyhydramnia, this was noted antenatally in the mother pregnancy. While this is not exclusive to Noonan syndrome, it can be associated with the condition. Neck mass, a posterior neck mass was probable at birth, which could be consistent with lymphatic abnormalities such as cystic hygroma observed during the fetal anomaly scan. The baby had a large birth weight for gestational age and macrocephaly, which can be seen in Noonan syndrome as well. The ECG shows AVNRT, which can be associated with structural heart defect, commonly seen in Noonan syndrome. There are some aspects that do not strongly support a diagnosis of Noonan syndrome. Normal knuckle translucency was normal in this case. Noonan syndrome can sometimes be associated with increased knuckle translucency, although this is not always the case. Absence of cardiac murmur. While congenital heart defects are common in Noonan syndrome, the initial examination did not reveal a cardiac murmur. Respiratory distress and pulmonary issues are generally not prominent features of Noonan syndrome unless complicated by other factors. Further history and examination that I will do to confirm the diagnosis of Noonan syndrome, including I've asked for family history. Is there any family history or genetic disorder, particularly Noonan syndrome or other syndrome associated with similar features? Assessing the feeding pattern as well, as feeding difficulties can be seen in Noonan syndrome. Perform a thorough examination focusing on other dysmorphic features of Noonan syndrome, including down slanting palpebral fissure, a short neck with wrapping, ptosis and widely spaced nipple, pectus deformities, cubitus valgus, and generalized lymphedema. Perform a thorough eye examination to assess visual acuity, presence of strabismus, and other ocular abnormalities.
Okay, so I need to stop you here. So you're too early on to discuss the differential diagnosis. What are the problems actually in this case? What are the medical problems? We are faced with this child when you're managing this case, presenting to you with those major problems. Is it really that crucial now to make a diagnosis to a syndrome? What is actually the problem here that you need to discuss? Go back to the first slide with all your problems. So obviously this baby has got a respiratory problem with a cardiac manifestation. Would you like to discuss more about how you're going to, how do you so-called think and discuss the problem that's facing the baby in the first few hours of life?
Okay, so as Prof. Cheah said, actually the child has acute issues, which is respiratory distress, recurring positive pressure ventilation and CPAP, and also intubated at 2 hours of life for the type 2 respiratory failure. So that is the main acute issues that we need to settle. And the other issue is the child has a tachycardia with heart rate of 210 due to AVNRT. So these two main issues that we need to settle during the acute presentation. So for the respiratory distress, I was thinking it could be due to GBS bacteremia or early onset pneumonia, and it could also due to the respiratory distress
half the time you don't see the P wave. The common ones, you don't see the P wave. The other types, you see the P wave after the QRX complex. Why you don't see the P wave is because most of the time the P wave is buried in the QRX complex. So in your typical SVT, you don't see a P wave in the ECG because the P waves are buried in the QRX complexes. But in certain types of AV-NRT we can further subdivide into three to four types. You can see the P wave. I have a graphical representation here. This is normal. So you see the P wave after the QRX complex, right after. So in a long lead 2, it's usually a negative deflection, like we call it a pseudo S wave, but it's actually a P wave. It's followed after the QRX complex. In chest leads V1, we usually see a positive deflection. We call it a pseudo R wave. Okay. So again, I've put up the ECG of the child. I've actually highlighted the long lead 2. So this child has a heart rate of 210 per minute. That's tachycardia. That is SVT. So, but other characteristics that this child has, the ECG shows a QRX complex, a very narrow QRX complex, less than 120 millisecond. Pseudo S wave. The pseudo S wave you can see right after every QRX complex. Okay, and this is actually the P wave. And the distance between the R wave and the P wave is less than 70 millisecond. So that is called a short RP interval. Short RP interval is characteristics of AV-NRT. So we have other subtypes where the accessory pathways are outside the AV node. Then you have your AV-RT, AV re-entrant tachycardia. It doesn't involve the node. So in that cases, you have a RP interval more than 70 millisecond. So this is how we differentiate between pure SVTs. You can see in Wolff Parkinson White, the delta waves, AV-NRT, AV-RT. Other kinds are atrial tachycardias like atrial flutter, atrial fibrillation. But that's a bit easy to differentiate because flutter and fibrillation, the atrial rate is much higher than the ventricular rate. Okay, so this is how we came up with the diagnosis of any AV-NRT. Management of AV-NRT is, or any atrial tachycardias, is similar to management of common SVTs. So adenosine, 2 to 3 doses, no response, amiodarone. We can even consider loading with other kind of antiarrhythmic. But normally neonates respond very well to amiodarone, and subsequently we can put them on maintenance. Usually for very young neonates, we use a beta blocker like propranolol, which is what we after the amiodarone we wean off and started propranolol for this child, and the child responded quite well.
Thank you very much, Dr. Anu.
Okay. I actually have another part which I will talk later after we discuss the differential diagnosis.
Okay. Yeah. Thank you. It's very clear. Thank you very much. So, Dr. Lim, Dr. Anu has come and helped with the diagnosis, confirmation, and treatment. And so, what is your concern now besides the arrhythmia? So there is signs of decompensation, right, because of the respiratory acidosis. And I can tell you that the lungs were pretty clear. I think Dr. Cheah will tell us more about the radiology findings later on. So you have to put the whole case into perspective. So are you not worried about the neck mass?
Yeah. So for the neck mass, I would like to order an ultrasound neck to further evaluate the posterior neck mass to see if there is any evidence or lymphatic malformation, any external compression and neck region, any evidence of any upper airway obstruction.
Yes, that's exactly why we should be worried about it, right? So you do not know whether the mass is extending and causing compression to the area. The lungs are quite clear, like I said, on the X-ray. So you want to radiology consult, right?
Yep.
Dr. Cheah, you want to help us to discuss? So we call the radiologist to help you for the neck mass.
Ini bukan saya punya. Sorry. Alright, sitting down there can give me a tachycardia there. Alright, so I'm going to talk about the radiological aspect of this patient.
So just to recap, Dr. Chai, fetal anomaly scanned by the obstetrician showed that there is a cystic hygroma. There was information given to us when the baby was delivered. So can you help us to sort this out? Yeah.
Okay,
Then physically, we saw the neck mass as described just now. Yeah.
Okay, so now we are talking about the neck mass. When we are being referred, we have to do the ultrasound at the bedside. So this is the quality of the ultrasound machine there. So, but this is what we can see. There is actually no lesion. All right, what we expect if they told us the antenatal scan has cystic hygroma, we wanted to see whether there is any locules of fluids or cysts at the neck region. Okay, those are the typical findings of a lymphatic malformation or cystic hygroma. But in this patient, there is no cyst, no channel, there is just subcutaneous thickening. So there is no focal lesion in it. So there is also no mass-like lesion there in the neck. So we can only see that this is the scan that we put on the patient neck. You can see that this subcutaneous is very thickened, right? And then it also extended a little bit towards the lateral part of the neck. I put up these two images just to show you that there was really nothing, no cystic lesion, no cystic channels, or there is not even any increase in the flow. So basically, we only see subcutaneous thickening, meaning thickened skin, all right? And then we did repeat the ultrasound neck sometime later, which is when the patient is about 40 weeks of gestation age. And this one this one is done in our department in HPKK. So you can see that the subcutaneous is still thickened. Even the skin is also a little bit thickened here. All right, this is at the lateral over the left side, and this is over the right side. And again, when we put the color Doppler on, there's no increased color Doppler signal. And we do not find any cystic lesion or any things that resemble a lymphatic malformation. So at this point, we are actually thinking whether it is just a subcutaneous thickening or there's a one type of lymphatic malformation which is called a microcystic lymphatic malformation. Sometimes the lymphatic channels is just so fine and it may be missed in the ultrasounds. But when we do MRI, we do see fluid signal intensity interspersed between the subcutaneous tissues. So this is a bit inconsistent with what we anticipated because of the antenatal scan. All right.
So Dr. Chai, this is localized, right? Dr. Lim is worried whether the
neck mass
is extending into the thoracic cavity. So is that an issue?
All right, so this is quite localized at the posterior and lateral part of the neck only, and we do check the mediastinum during our first ultrasound. I'm sorry I didn't put in the images here, but the mediastinum was clear, and then the soft tissue thickening was also not involving the chest or anywhere nearby the anterior neck region. Right, so we can safely say that at this point of time, we are not worried about the upper airway compression or any mass-like lesion that is sitting there in the patient.
And would you like to comment on the chest X-ray, which I just
Sure.
now briefly said?
So just now when Prof said the chest is pretty clear, I was worrying down here because this is the chest radiograph that we had at birth. This is at birth, and this is day 5 of life and day 13 of life. But you can see that across these 13 days, the chest is getting clearer. Right, initially, we do see slightly low volume of the chest, a little bit of bell-shaped appearance here, and there is also diffuse ground glass opacity in bilateral chest lung fields. So these are suggestive of respiratory distress syndrome, but a mild one, all right, because the cardiac ciliate and the diaphragm outline is still pretty well seen. So across the days, which is day 5 and day 13, you can see how the ground glass opacity actually start clearing up. And at the day 13 of life, the lung is quite clear, I would say. All right. The other thing to note is that the rice tube, the side hole is not in situ. right? This is not the proper place for the rice tube because we have side holes in the rice tube. All this supposed to be in the stomach bubble here. So it's same go to the rest of the chest schedule.
Thank you, Dr. Chai. I was just redirecting Dr. Lim to the neck mass. The baby did have some mild respiratory distress, like you described nicely, but it was not really an issue. So we managed to settle it and stabilize with the respiratory support. So now the neck mass, Dr. Lim, the neck mass by Dr. Chai is not cystic hygroma. It's nothing really significant. It's probably nuchal thickening, right? And with that, can you discuss on the differentials of a child with the nuchal thickening probably and the tachycardia? Before you give your exhaustive list of differentials and all that, what comes to mind when we have a child with nuchal thickening? What are the common conditions?
Um,
And usually it's done on antenatal scan. The obstetrician or the fetal maternal specialist will do an ultrasound and say, oh, this baby has got nuchal thickening, and they have a measurement for it. So what are differential diagnoses for conditions with nuchal thickening?
okay, so my differential diagnosis would be genetic syndrome.
Like what?
Costello syndrome.
No, most commonly nuchal thickening.
Noonan syndrome.
More common than that.
Turner syndrome.
More common than that.
Trisomy 21.
Yes.
Down syndrome.
So nuchal thickening is associated with trisomies or monosomies. So trisomy 21 or monosomy like Turner's. These are the conditions that you must think about, yeah? Okay. Anything else you want to discuss about the problems? I think we kind of know what are the major problems now with the child. And you want to finish your discussion of your genetic syndromes you are thinking about with in this child before I call Dr. Azah to
Okay.
discuss.
Okay, so Turner syndrome is also one of the differential diagnoses that are considered in the genetic syndrome. So point 4 is dysmorphic features. The newborn has characteristic feature associated with Turner syndrome, including hyperthyroidism, micronectia, almond-shaped eye, and low-set ear. Polyhydramnion noted antenatally in the mother, and although not specific to Turner syndrome, it can sometimes be associated with fetal anomaly, including those seen in the Turner syndrome. Okay, so the posterior neck mass just now already mentioned is not cystic hygroma, so it's not the characteristic findings in Turner syndrome. So point against is the knuckle translucency was reported as normal during the antenatal scan. So in Turner syndrome, increased knuckle translucency
No, we
can
just said
sometimes be observed.
it probably was a misdiagnosis. The cystic hygroma was actually nuchal thickening, right? We have discussed that already.
Okay. So just to add on, like what I say, the child might have some component of sepsis as well in to contribute to the overall clinical picture of this patient. The sepsis that we'll consider are GBS bacteremia and early onset pneumonia. So the maternal GBS carrier status, deliver spontaneous vertex delivery, and respiratory distress and tachycardia as part of the systemic inflammatory response. And sepsis can contribute to electrolyte imbalance, hypoglycemia, hyperlactemia, and elevated PCT. Point against the sepsis, including there is no leaking liquor, the mother was adequately covered with ampicillin, so it will mitigate the risk of severe sepsis-related complication. Further history and examination that would ask, including the maternal history and any detailed delivery process and onset and progression of the symptoms such as the respiratory distress and any other signs of any systemic infections, including fever, hypothermia, hypotension, and sign of organ dysfunction.
Okay, we worked this out and there was no GBS and there are no sepsis. Okay, move on.
So the last was respiratory distress syndrome, which was discussed and confirmed with radiologist Dr. Cheah.
Okay. You had a slide on congenital infections. You want to briefly go back to that again? Yep, this one. No, there's a congenital infections. No, further.
CMV.
Yeah, that one, CMV.
Okay, so for point for congenital infection, that I would think is a cytomegalovirus. So point 4 is polyhydramnion, and this can be associated with congenital CMV infection. And also dysmorphic features, baby with congenital cytomegalovirus can present with some dysmorphic features, hypertelorism, micronectia, almond-shaped eye, and low-set ear. And respiratory distress, recurring intubation, CMV can cause pneumonitis and respiratory distress in neonate. And also hyperbilirubinemia, hypoalbuminemia, and abnormal liver function tests can be seen in congenital CMV due to hepatic involvement. So point against cytomegalovirus, including the neonate presented with respiratory distress immediately after birth, which is more suggestive of respiratory distress syndrome rather than the gradual onset typically seen with the congenital CMV infection. CMV-related respiratory symptoms often manifest later, typically within the first month of life. Apart from that,
do you think this baby has got some form of hydrops fetalis?
No.
No. Why?
No.
When they presented with that neck mass, could that be a resolving hydrops? What was it in the initial presentation in terms of the biochemistry? It's suggestive of this may be a form of hydrops. So what causes hydrops fetalis besides congenital infections like you're presenting here? Could the baby have got heart failure causing some form of hydrops and resolving now? Since you got the arrhythmia.
Yeah,
so those are things to consider, isn't it? So maybe some form of resolving hydrops and those hypoalbuminemia and all as well. Yeah?
Okay.
Okay, so I think that's all. You have slides. Dr. Azah, you want to... Oh, sorry, Prof. Wong has got a question.
Dr. Lim, obviously the acute medical problem is being settled. You got a genetic problem that you have given to us. From the genetic syndromes, very difficult for the medical students to remember all the signs and symptoms. What is the unifying feature in those syndromes that you have discussed, especially the first two? And how do you distinguish Noonan and Costello in the pathogenesis?
Okay. So, to differentiate the Costello syndrome and also Turner syndrome, Noonan. Genetic testing is crucial to.
Why is it? Which pathway are they involved in? What abnormality does it cause? What genetic mutation results in what the manifestation? The multi-system manifestation.
It actually involves the proto-oncogene, the RAS MAPK signal pathway that contribute to the gain of the function of the proto-oncogenes that contribute to the syndrome.
And how are they closely, how are they linked? These two syndrome, are they closely linked in that pathway?
Yep. Both belongs to the rasopathies pathway.
And how
involved in
does
the
it explain the manifestation, the rasopathy? Maybe Dr. Azah will tell you.
Yes, Prof.
Thank you, Prof, for the question. So, Dr. Azah, can you illuminate us further of this condition?
No.
So obviously, while Dr. Azah is preparing her slides, obviously, we didn't arrive at the diagnosis of Costello so quickly. We settled all the acute problems, and we think this child is dysmorphic. With all these associated conditions, certainly we have to think of a syndrome, yeah? For students, that's how we work out the case. So, of course, to diagnose syndromes, nowadays we just don't do a chromosomal anomaly as test or chromosome analysis because it just gives you the numbers. We go to a more extensive genetic testing in terms of whole genome or whole exome sequencing. It will tell us more details about the genetic mutations that may be present in a lot of syndromes. Because a lot of syndromes may not have just numerical karyotype anomalies.
Yes, that's precise.
It's all genetic mutations, right, which you need to be sequenced on a genomic or exome sequencing. Dr. Azah will tell us more about this. Thank you.
Thank you so much, Prof. Cheah. Prof. Wong, I will answer your question in a very clear manner after this. So I'm going to continue the presentation. So just to have a recap of what the case is a preterm baby girl at 34 weeks with a birth weight of 3.28 kilogram. So antenatally, there was polyhydramnios with fetal anomaly scan of cystic hygroma and enlarged cysternal magna, and the child was not vigorous, required intubation because of type 2 respiratory failure. The child had facial dysmorphism, was tachypneic and tachycardic, with a posterior neck mass of 4 times 5 centimeter in size, and the cardiovascular examination was femoral distal pulses were felt, and there were good volume, apex was not displaced, and there was no murmurs. This is at birth. And based on the diagnostic testing that we have done, Dr. Anu has mentioned regarding the ECG, there's AVNRT, the torches were negative, and echocardiogram and radiological imaging has been mentioned. And we did the karyotype, which was actually 46XX. And we proceeded with whole exome sequencing. This is where KRAS heterogeneous pathogenic variant were found, and it matched the history and clinical manifestation. So the final diagnosis is Noonan syndrome. We just want to go back with the progress of the patient. The patient required NICU stay for 22 days, invasively ventilated for 4 days, requires surfactant and IV CPAN and gentamicin, and the AVNRT was reverted with adenosine and amiodarone as mentioned by Dr. Anu. The ophthalmology and ENT was normal. The child did have feeding, suckling, swallowing incoordination, which require RAS tube feeding upon discharge. Now she is 8 months old, 6.5 corrected gestational age. Her growth is within 25 centile. However, she was just admitted 2 weeks ago to Hospital Serdang for aspiration pneumonia. She has developed hypertrophic cardiomyopathy even at 8 months on beta blockers, on propranolol, and she's on RAS tube feeding, and she's on anti-reflux and medication for GERD, and she's developmentally delayed. She's development is about 3 months old. Let's look at the historical perspective of Noonan. So this is Dr. Jacqueline Noonan. She's a pediatric cardiologist. She passed away sadly 4 years ago at 92 years old. She has reported in 1962 14 patients with valvular pulmonary stenosis that has dysmorphisms and short stature, hypothyroidism, ptosis, learning disabilities, undescended testes, and skeletal malformation. 40 years down the road, they identified the first genetic mutation, which is PTPN11 gene, and subsequently, I will illustrate to you multiple genes have been identified. So essentially, it is a genetic multisystem disorder. We will go through the distinctive facial features. There will be developmental delay, learning difficulties, short stature, congenital heart disease, renal anomalies, lymphatic malformation, and bleeding disorders. About 70% inherited by autosomal dominant. The prevalence is 1 to 1,000 to 1 in 2,500 in the States. We do not have a data in Malaysia. And the mutation, as Prof Wong has asked Dr. Lim, I will explain about the RAS-MAPK pathway. So for the interest of the students here, we will talk about what is autosomal dominant. So it is a vertical transmission with 50% chance of being affected. And there is 8 gene, PTPN11 is the most common. Our patient is KRAS gene, which is less than 5%. At 12p, 12.1, I will show you this schematic diagram of what this is. And if you have a parent that has D, the capital D here is the gene dysfunction, you have 50% chance of having a child developing this condition regardless of gender, and 50% chance of it being unaffected. So let's go back to basic genomics. This is the most basics of all basics. Yeah. So we know that the cell has nucleus inside. 99% of our DNA is in our nucleus, but 1% is in mitochondria. There's a chromosomes. The chromosomes are made of DNA structure. If you unwind it, you will have a gene and a DNA, which is double helix, with guanine, cytosine, adenine, thymine base pairs. Why is this important? Because you have to understand that KRAS in this patient, which is Noonan syndrome, the chromosome is chromosome 12. So this is chromosome 12. P means the short arm of the chromosome, and 12.1 is the band. So this is actually the address or GPS, if you want to say, where is the KRAS mutation. Right, this is rastopathies. So if you read about Noonan syndrome, you're going to bump into these rastopathies. So but what is rastopathies is RAS, mitogen activated protein kinase MAPK signaling pathway. If you want to signal your car to the right, you will, put the signal on the right. If you want to go to the left, you put it on the left. Basically, the cell will talk to one another via cell signaling pathway. So this is RAS, and the whole system here is MAPK. As Dr. Lim has mentioned, it's proto-oncogenes, right? There's multi overlapping syndromes. The pink one are Noonan. But if you look at the whole pathway, you can see neurofibromatosis type 1 here. You can see Costello syndrome. So that's why there's overlapping features. And you have, for example, NS-like syndrome and Noonan syndrome, but they can have juvenile myelomonocytic leukemia. And this is extensively studied because there is a specific treatment for this. And it is a genotype-phenotype correlation. When there is dysregulation, what happens is it keeps on replicating. So this cell division replicates, there's mitosis and there's no inhibitions. So that's why it can be prone towards malignancy and any other growths. Again, it is a multisystemic manifestation. It varies according to system. It matches antenatal history, neonatal and physical examination, and childhood until adolescence. So antenatally, nuclear translucency here, as you can see, is clearly depicted here, not only in Down syndrome, but also in Noonan syndrome. You have polyhydramnios, limb shortening, and female macrosomia. In any fetus with nuchal translucency, polyhydramnios, and cardiac anomalies with a normal karyotype, you have to suspect Noonan syndrome. We don't have a picture of the child because of the parents do not consent to it. But this is a child, Algerian, that I found in one of the journals. You can see broad forehead, there's hypothyroidism, there's long phitherum, low set here. Wispy hair is very thin, sparse hair, down slanting eyes, small chin, and there is a bit of neck webbing. It changes from newborn to infant, right? If you look at infant, if they do not diagnose at newborn age, you can have wispy hair again, thick hooded prominent eyes, wide base, depressed nose, bulbous upturned tip, and also cupid brow appearance of upper lip. What if they're bigger? There we are. So we have a child, a bigger child, with woolly hair, like wool-like hair, and a white forehead, there's skin webbing and small chin. And if into adolescence, they have this high anterior hairline, triangle-shaped head, transparent wrinkle seen, and prominent nasolabial folds. This is a picture of 5 generations of Noonan syndrome. This was published in The Lancet in 2013. I would think from this picture, the first generation is, I don't know, Prof. Cheah, I think looks very handsome to me. And compared to the second and third and fourth and fifth, it's more pronounced and more, you can see the broad forehead and then the neck webbing in subsequent generation.
Dr. Azah, do they look progressively more obvious?
Yes,
Because
I
the
think
first
so.
generation was very mild and then it sort of progresses, isn't it?
Yeah, and I think the girls here, I mean, this lady does not look like Noonan if you know, at the one glance. So this is a very good picture of 5 generations of Noonan syndrome. The cardiac manifestation commonly is pulmonary valve stenosis, about 40 to 50%, and hypertrophic cardiomyopathy in about 30%. They can have septal defects, atrial or ventricular, or atrioventricular canal defects. And in this patient, even at 6 months old, corrected age, the child already has hypertrophic cardiomyopathy, which is a poor prognosis for the child. So why do they have hypertrophic cardiomyopathy? Again, coming back to the RAS-MAPK pathway. So if you look at PTPN gene is the commonest gene for Noonan syndrome, and you have this RAS, you have dysregulated cell proliferation over mesodermal development. Mesodermal development, if you look at embryology, is where your cardiac cells comes from. So proliferation of these cardiac muscles lead to hypertrophic cardiomyopathy. It leads to thickened ventricular septum, and it may lead to right ventricular outflow tract obstruction or left ventricular outflow tract obstruction. And what about the lymphatics? So in this patient, you have lymphedema. Again, the RAS-MAPK pathway can affect your lymphatic venous system because hyperactivation and dysregulation. This is where syndromic manifestation is. You have primary lymphatic anomaly, primary lymphedema, and this is known syndrome, rasopathies, again, at this site.
So the nuchal thickening, the neck webbing, and all those things are manifestations of the lymphatic
dysregulation,
anomalies,
yes.
like Dr. Cheah described.
Exactly, Prof.
Even on ultrasound in day 1.
Yes, and there's a lot of overlapping syndromes as well. If you have rasopathies, the pathophysiology of it is the lymphatic venous system that is hyperactivated and dysregulated. In the interest of musculoskeletal, there is dysregulation of IGF. So basically, RAS-MAPK pathway here, you have the growth hormone. They need to bind to growth hormone receptors, and JAK2 is there is a connection between MAPK and JAK2. So when you have MAPK, RAS-MAPK dysregulation in Noonan syndrome, the whole system is dysregulated. So you have abnormality in IGF. So basically, IGF is for growth, so that's why they have limb shortening and also short stature. One of the treatment is actually growth hormone in Noonan syndrome. So how do we diagnose if you clinically? So there is a diagnostic consideration. You need to have facial dysmorphisms and one major. One major is either cardiac, height, chest wall, family history, or other features. If you have suggestive facial dysmorphology and 2 features, or you have 3 minor features. So you have major and minor. And in this patient, you can see the child has suggestive facial dysmorphology. You have hypertrophic cardiomyopathy and also lymphatic vessel dysplasia, which makes the diagnosis very likely. Again, this is a schematic representation of what features of Noonan syndrome is. And this side is what we have mentioned just now. So the management is a team effort of various subspecialties. So when you go out trainees, sometimes you wouldn't have all these specialties with you. You are the pediatrician in charge. So you need a neonatologist, cardiologist, ophthalmologist, ENT, and you have to refer to geneticists if there is available, and developmental pediatrician and endocrinologist if there is actually growth failure. For the developmental delay, speech therapist and dietitian is important for feeding difficulties, and physiotherapists, occupational therapists, and school as well when they go to their school-going age group. So the learning points for this case is again, Noonan syndrome is a genetic multisystem disorder. There's a lot more overlapping syndrome, which is the restopathies, and there's varying manifestation from newborn to adulthood with multiple comorbidities. So you need to have a high index of suspicion and the importance of genetic testing. I would call Dr. Anu just to give a highlight on hypertrophic cardiomyopathy in Noonan syndrome.
So, Dr. Anu, when you were helping with us, helping to manage this case with the arrhythmia, you obviously also did the echo, right?
Yes.
At that time, did it show any structural anomaly?
Yep. Okay. I'll just show. Right. Unfortunately, I do not have the echo done at the neonatal period in NICU. I think throughout the NICU stay, I did 3 echoes, 3 or 4. I can't remember because I was like repeating it almost weekly basis. The child did stay quite long. Yeah. So you just have to take my word for it. Structurally, there was no heart defect noted at the newborn period except for the PFO and PDAs. The septums were normal and there was no peripheral stenosis. Okay, for Noonans, the most common cardiac diagnosis is valvular pulmonary stenosis and also peripheral pulmonary stenosis, which could be your RPA, proximal RPA stenosis or right or left pulmonary artery stenosis, not specifically valvular. Okay, 65 to 70%, this is their manifestation. Second most common cardiac diagnosis is hypertrophic cardiomyopathy, and normally they develop hypertrophic cardiomyopathy at around 5 to 6 months of age. Hypertrophic obstructive cardiomyopathy or HOCM in a baby with no genetic issues usually can happen very late, 6 to 7 years. Common median age of presentation is around 8 years old. But in patients with restopathies, usually happens very early within the first 6 months of life. So in this child, I will show you. Okay. So this, after that, the child got discharged. She went back home. I saw her in my clinic at around 3.5 months of age. I'll show you I need to show you.
So while Dr. Anu is looking for her slide, any questions from the floor? We're going to wrap up soon in just a couple of minutes. No questions, students, trainees, faculty members?
Okay, this is actually a long axis. This is the echo done at 4 months of age. This is actually a long axis view. So what we can see is this is the interventricular septum, a very hypertrophied interventricular septum with the hypertrophied left ventricular posterior wall. And during systole, they actually meet in the center. And what the other thing that I wanted to show was the mitral valve. The anterior mitral valve leaflet is sucked into the LVOT during systole. This is what we call SAM or systolic anterior motion, which happens in very severe LVOT obstruction. So this is hypertrophic obstructive cardiomyopathy, which was not there during the neonatal period. And this is the subcostal 5-chamber view. which we can see how hypertrophied and thickened the LV was. So this happened to the child within the first 4 months of life. So in Hokum, if we look at all the rasopathies, Hokum is more common in Castello. Castello 60 to 65% develop Hokum compared to Noonan's. But both in Noonan's or even Castello, the earlier the presentation of Hokum, the poorer prognosis. So if the child develops Hokum before 6 months of age, chances of developing congestive heart failure is very high, and the chances of having sudden cardiac death before the 1 year period is also very high. So what I did after I saw this echo at around 4 months, we referred this patient for possibility of myomectomy, which is not done for young infants, but that's the only choice or hope that we have if we want the child to survive longer. So she was sent to Hospital Serdang, but because of her age and her weight, she is not suitable for myomectomy, so she's still on follow-up with them there.
So what medical treatment is the choice of therapy now for the Hokum?
The end point for patients with Hokum in Noonan syndrome who develop cardiomyopathy so early is usually cardiovascular death. And what leads to the cardiovascular death are two main things. One is congestive heart failure. Second is arrhythmias, not AV NRTs. AV NRTs is not life-threatening. They will go on to develop ventricular tachycardias. Because of the hypertrophy of the ventricle, they will go on to develop fatal ventricular tachycardias. So what in overseas, what they do, they can insert internal cardiac defibrillator, ICDs, which we do not do in Malaysia. We do not do for such young children because ICD gives shock. So when ICD detects VT, it will give shock, and children can't withstand the shock. It's very painful. So this child...
And any treatment to regress the hypertrophy?
We only give treatment to reduce the heart rate because we want to improve the cardiac output. So normally we give propranolol, beta blockers. The main treatment for Noonan's is, if in this kind of cardiomyopathy, is usually myomectomy. So you have to excise the excessive myocardium to improve the alveolar obstruction.
Okay. Thank you
so
very much.
If she survives a bit longer, she puts on a bit more weight, she will be a candidate for surgery in the future.
Thank you. Dr. Azah, what's the normal lifespan for Noonan's?
If they do not have any cardiac disorder, Prof, it's actually normal, just like any other person. But the limiting, most devastating is actually the cardiac anomalies. So that's why sometimes, Prof, Noonan syndrome is not diagnosed. So that's why we have to have high index of suspicion. Yeah.
Right. Well, something to say, Anu? Last words.
For Noonan's with Hokum, life expectancy at age of 15 is around 70%.
Well, thank you very much. Excellent discussion by the team. And no questions, I gather, from the students? Well, I hope this CPC has taught you what a clinical pathological correlation is. You know? So we presented the medical issues in a clinical way, and then we tie it together with the underlying science. So hopefully you all like this. If you like it, you can vote for a pediatric CPC as one of your favorite ones, because there is going to be a competition even. And you yourself, who attend, you can also get a prize at the end of the year, I think, if you attend and get the quiz questions, I think, correctly. I think after this, for students, there'll be a quiz, yeah? Okay, so I think we are really past time, about 10 minutes past. So I thank you all for attending, and hope you have a good day. Thank you.